Hello, future doctors. How are you all? Welcome back to MedSteps General Surgery Series. Today, we are going to discuss very important topic by Dr. Anand, that is large bowel obstruction. So, imagine an elderly patient presenting with progressive abdominal distension, constipation for several days, and intermittent crampy pain. Unlike small bowel obstruction, vomiting is late and minimal. On examination, the abdomen is massively distended like a drum. Hidden inside, the colon is gradually dilating, wall tension we can see is increasing, and blood flow is being compromised. And if not treated in time, the bowel may perforate, leading to feculent peritonitis, and the patient can lead to septic shock. So, large bowel obstruction is less common than small bowel obstruction but more dangerous when perforation occurs because of more amount of feculent feculent substance, and it will cause peritonitis, and it will lead to septic shock, and it's mostly often seen in elder patients with malignancy. So in large bowel obstruction, time is colon, delayed in diagnosis leads to perforation and sepsis. Okay, so today in this lecture we are going to learn many things. By the end of this section, you should be able to define large bowel obstruction and understanding pathophysiology and identify causes and risk factors and recognize clinical features and differentiate from small bowel obstruction and learn initial management, prepare for surgical decision making. Okay, so without time waste, let's start. So first of all, we can see here that is definition of large bowel obstruction. So in definition, we can see here large bowel obstruction is the partial or complete blockage of the passage of feces and gas through the colon or rectum due to mechanical or functional causes. Okay, so in simply we can call large bowel obstruction is a blockage of colon, and it prevents the passage of stool and gas, and the bowel will become dilate, and the patient will become risk of perforation. Okay, so this is the main condition. It will be like medical emergency condition, and it's common cause of chronic perforation and high mortality in delayed cases. So in we will discuss little amount of surgical anatomy of colon. You can see here this is the parts of large intestine. You can see this is the part we call cecum, and this is the part we call appendix, vermiform appendix. And you can see here this is the ascending colon, and this is we can call the hepatic flexor. Okay, this is hepatic flexor and this is splenic flexor, and you can see here this is transverse colon. Then after this is descending colon, and it will go S shape, so this is sigmoid colon, and you can see here that is rectum. Okay, so here this is the main large intestinal structure. You can see this is hepatic flexor and splenic flexor because the structures is very close to here, and this is ileocecal wall. Okay, and in large intestine we can see some movements we call Haustra movements. This is the movements and this is the Haustra structures we can see, and then another things we can see some fat like structure we call that is tinea. Okay, this is tinea. These are things very important because this Haustra structures and tinea, these are the things we can see in X-ray. Okay, so that's why these are things important. If you're seeing this, the structure of the histological structure, if you're seeing means in large intestine, you can see more amount of openings of crypts. It will help to absorption. Okay, and we can see more amount of goblet cells and mucosal cells and crypts. Okay, and we can see longitudinal and transverse muscle layers also we can see. Okay, so these are the main things. So next you can see here that is blood supply of large intestine. We can see here that is in proximal large intestine, you can see superior mesenteric artery, and that the superior mesenteric artery will cover the proximal colon, and you can see another one inferior mesenteric artery. That inferior mesenteric artery will covered by distal colon. Okay, so In superior mesenteric artery, you can see like arteries of right colon like middle colic artery, right colic artery, and ileocolic artery, and distal terminal superior mesenteric artery. Okay, so these are the things. In inferior, you can see arteries of the left colon like left colic artery, sigmoid arteries, and superior rectal artery. So here in rectum, you can see superior rectal and middle rectal and inferior rectal. So these are the things mostly important in hemorrhoids. Okay, when we are discussing about hemorrhoid, that time we can discuss. I already made one video about hemorrhoids. So if you didn't watch that video, you can watch. So there I already covered something, a little amount of anatomy also. Okay, so the sigmoid colon is the most common site of volvulus and obstruction. So that is the main thing. So we can divide this large bowel obstruction based on classification. First one, you can see same to same like small bowel obstruction. How we discuss same to same pattern I'm following here. So in classification of large bowel obstruction, first one we can see mechanical large bowel obstruction. That means physical blockage in colon. Second one, you can see here functional large bowel obstruction, that is pseudo obstruction. You can see no mechanical blockage. And the example we can, in example we can see like Ogilvy syndrome. Okay, that is functional dysfunction. Functional blockage, no functional blockage. We can see functional blockage. Okay, and no mechanical blockage. So next you can see that is based on severity. We can classify large bowel obstruction, that is related to partial or complete obstruction. Next we can see some complications, that is based on complications like simple obstruction and strangulated and ischemic colon, that is less common than small bowel obstruction. Okay, next you can see here that is pathophysiology. In this pathophysiology, we can see first of all the patient will get obstruction in colon. So that is the main obstruction in colon, and it will accumulate in accumulation of feces and gas. Then after we can see it will lead to progressive of colonic dilation. Then after it will increase intraluminal pressure. Then after we can see reduces venous return and ischemia of bowel wall, and it will lead to necrosis. Next, at last, perforation, usually in cecum, and we can see fecal peritonitis. Then after we can see sepsis and shock, and at last death. So this is the main cecum is the most common site of perforation due to Laplace law, that is highest wall tension. So in cecum we can see highest wall tension, we called that is Laplace law. So because of this law, we can see more amount of common site perforation will be occur in cecum. Okay, so next we can see how the symptoms will get in large bowel obstruction means. First of all, obstruction. In obstruction, you can see that is like loss of normal peristalsis. Then after we can see proximal colonic dilation. Then after we can see like water absorption. It continues. Then the stool will become hard. Okay, so we can see hard stools, and it will and the large bowel we can see progressive, it will become distension. Then after mucosal ischemia, then after the bacteria will become translocation. Then after at last we can systemic infection will be in risk. Okay, in clinical correlation we can see like a distal obstruction in severe proximal distension, and we can see cecum. The cecum will be like greater than 12 centimeters diameter means that means the patient have risk of perforation. Okay, so next you can see here causes of large bowel obstruction. The most common cause we can see, and we have a mnemonic for large bowel obstruction causes, that is Chwad hip. Okay, Chwad hip means C means cancer, H means hernia, VA means volvulus, D means diverticular disease, and hip means H means hernia, I means inflammatory bowel diseases like Crohn's, okay, and P means pseudo obstruction. So first of all, the most common cause, that is colorectal cancer. So in colorectal cancer, you can see that mostly we can see most common in adults. Next, volvulus. Volvulus, we can see two different types of volvulus. One is sigmoid and fecal. These are the most common. So sigmoid most commonly we can see in elderly patients. Fecal will be in like children. Okay. Next we can see that is diverticular disease. That is in diverticular disease we can see structural formation. Next fecal impaction mostly you can see in elderly and bedridden patients. And hernia, it's very rare in large bowel obstruction, most common in small bowel obstruction. And inflammatory bowel diseases like Crohn's strictures. Next we can see pseudo obstruction like Ogleve syndrome, like we discussed in classification. So next you can see that is risk factors of large bowel obstruction, that is early age like greater than 60 years, low fiber diet, chronic constipation, colorectal cancer of history of cancer, previous abdominal surgeries, neurological diseases like where it will reduce peristalsis movement and reduce motility, bedridden patients and dehydration. So this colorectal cancer is the most common important cause of large bowel obstruction in adults. So clinical features. In clinical features, we can see that is cardinal symptoms. You can see here in cardinal symptoms, mostly the patient first presented with progressive abdominal distension. Next, constipation. It's like constipation is also absolute in obstipation, incomplete obstruction. Next, abdominal pain. We can see that is abdominal pain also like crampy or dull pain. We can see and vomiting. Then after vomiting also in late futures, we can see then after failure to pass flatus, gas passing. Okay. In key differentiation, in small bowel obstruction, we can see early vomiting. In large bowel obstruction, we can see like late vomiting. Okay. So these are the things. Next, we can see here that is physical examination. In physical examination, whenever patient coming with uh, large bowel obstruction, first we have to go with general inspection. So in general inspection, we can see symptoms of dehydration and tachycardia and fever if complicated. Next, in abdominal examination, first we have to go with inspection. Inspection like abdominal distension and visible peristalsis. Then after we can see surgical scar marks and hernias. Next, in palpitations, we can see mild tenderness and mass like possible tumor. And next, you can see guarding in late sign and tympanic abdomen. We can see. Okay. In percussion, we can see like a tympanic abdomen, hyper resonant and gas filled colon. In auscultation, high pitched bowel sounds we can see in early stage, and silent abdomen we can see in late stages. Okay, so these are the main things we can see in large bowel obstruction. Next, you can see here that is red flags. Whenever patient coming with large bowel obstruction, if patient getting like continuous pain, that is emergency signs like continuous pain like not colicky and fever, tachycardia, guarding, rigidity, and rebound tenderness, shock, and leukocytosis, and it suggests ischemia or perforation. Okay. Next, you can see here types of large bowel obstruction, that is like simple. Types of large bowel obstruction total we have 4 different types. One is simple obstruction, that is blood supply intact. Next, we can see strangulated obstruction, that is ischemia will present. Next, you can see closed loop obstruction, like rare in colon but dangerous. Pseudo obstruction will be like no mechanical cause. So sigmoid volvulus. Sigmoid volvulus is the closed loop, classic closed loop obstruction, that is sigmoid volvulus. Okay, so this is we call classic closed loop obstruction. For example, you can see here, this is the main picture you can see, that is volvulus. Okay, so volvulus means it will look like this. So what it means? Volvulus means twisting intestine. It may be you can see in sigmoid colon or cecum. Okay, so here in volvulus means that is like twisting of bowel around its mesentery, and it will lead to obstruction plus ischemia. So the most common sites you can see, that is sigmoid colon is most common. Next, you can see that is cecum. In clinical features, you can see massive distension, pain, constipation. So in danger, like it will progress to gangrene because of ischemia. If anything got twisted like this, whenever it's twisted, the blood flow will obstruct So it will lead to um, gangrene. Okay, so that is the main things. Next you can see here, this is the another picture of volvulus. You can see this type of thing, and you can see obstruction of blood flow. Okay, so this is another image you can appreciate here. So this is sigmoid colon getting twisted, and here also sigmoid colon got twisted. Okay, so this is real picture. I took picture in while doing general surgery department. That time I saw this type of toxic megacolon. Okay, so these are the things. So we have some differential diagnosis. Whenever the in large bowel obstruction, whenever the doctor asking differential diagnosis, we have to tell these things. That is first one, small bowel obstruction. In small bowel obstruction, how we can differentiate with early vomiting. Next, we can see that is paralytic ileus. In paralytic ileus, we can't see any bowel sounds, so no bowel sounds. Toxic megacolon. So this is toxic megacolon. You can see this type of big picture. Okay, so toxic megacolon means it's like patient have inflammatory bowel disorders history like Crohn's disease or ulcerative colitis. Next, we can see constipation, no obstruction signs. Next, mesenteric ischemia like severe pain out of proportion. Okay, so these are the things. Next, we can see um, the main important things of before doing any diagnostic approach. Before seeing that patient, we have to understand some important things. That is like mostly large bowel obstruction will be like mostly present in elderly patients, and cancer, mostly cancer, or until proven otherwise in elder patients. Distension is more severe than small bowel obstruction. Vomiting is late. Cecum is at highest risk of perforation, and always we have to rule out malignancy. Okay, so these are things. Next, you can see here that is diagnostic approach of large bowel obstruction. The main goal to evaluate the confirm the patient have obstruction or not, and identify the level of colon or rectum, and we have to identify the cause like cancer, volvulus strictures, or we have to detect complications like ischemia and perforation, and we have to decide the urgency of surgery. So we have to follow the algorithm like diagnostic approach. First of all, we have to check symptoms like distension, abdominal distension, constipation, and pain. Then after, we have to do clinical examination. Then after, we have to do some lab test, like then after abdominal x-ray, then after CT abdomen. Our CT abdomen is the best gold standard test for large bowel obstruction. Or with or without colonoscopy. In selected cases, if elder patients, we have to do colonoscopy. That is the best option. Next, we have to do diagnosis. Then based on the patient condition, based on lab results and imaging, we have to do management. So whenever patient coming, first we have to focus on primary assessment, then after in history taking, then after physical examination. In history taking, we have to ask the patient of duration of constipation, and if patient have obstipation like no stool and no gas, we have to ask that questions everything about large bowel obstruction, like progression of abdominal distension, patient have any vomitings, latent large bowel obstruction, and weight loss, like if you're suspecting malignancy, and blood in stool like colon cancer, like previous episodes like volvulus, pseudo obstruction, and past surgeries, and chronic constipation history. So the weight loss, anemia, and um, altered mental, altered bowel habits. Then after, we have to think colorectal carcinoma until proven otherwise. We have to rule out other things. Okay. So next, we have to go with investigation. In investigation, first we have to go with labs. In labs, we have to check um, CBC like white blood cells. The white blood cells normal level will be like 4,000 to 11,000, and in large bowel obstruction we can see increasing leukocytosis. So it will lead to ischemia or infection. Next, hemoglobin. In males, we can see 13 to 17 grams per deciliter. In females, we can see 12 to 15 grams per deciliter. That means if in malignancy, it will reduces. Okay. So next, sodium. Electrolytes. Sodium, the normal level will be like 135 to 145 millimole per liter. If the sodium is reduced, patient getting hyponatremia, it will lead to dehydration. Next, potassium. The potassium level, normal level will be like 3.5 to 5.0, and it will lead to reduced due to vomitings and nasogastric losses. Next, we can see urea. The urea will be like the urea normal value will be like 7 to 20 milligram per deciliter. If this 7 to 20 milligram per deciliter means that means it's causing, it's like it's very prone to get a patient have increasing dehydration risk. Next, we can see that is creatinine level. Creatinine level normal like 0.6 to 1.2 milligram per deciliter. That means renal impairment in shock. Next, we can see CRP, C-reactive protein, like less than 5 milligram per deciliter. That means increasing inflammation. Next, we can see lactate. Lactate means 0.5 to 2.2 millimole per liter, and it will increase risk of ischemia. And it's raised if patient have lactate. If the lactate is raised means, that means the patient have bowel ischemia. So this is the warning sign. Okay. So next we have to go with ABG, arterial blood gas. So this ABG normal values we can see like the pH value will be like 7.35 to 7.45, and the bicarbonate will be like 22 to 26, and the partial carbon dioxide will be like 35 to 45 mmHg. So the ABG, it will help to finding of large bowel obstruction like metabolic acidosis. This metabolic acidosis we can see in ischemia and perforation. Next, we can see respiratory alkalosis in early stress response. This acidosis will be like late danger sign, and it considers strangulation and perforation. Next, we can see here that is abdominal X-ray. The abdominal X-ray we can see like erect and supine films, and in abdominal X-ray we can see like marked colonic dilation, haustral markings, and multiple air fluid levels. And we can see peripheral dilated colon and coffee bean sign. You can see in sigma. Okay, coffee bean sign. When you can see that is coffee bean sign of coffee bean sign. If you're seeing means that is sigmoid volvulus. Okay. Next, bent inner tube sign. If you're seeing means that is fecal volvulus. Okay, so the coffee bean sign means that is volvulus. So you can see here this is normal X-ray. So in normal abdominal X-ray you can see this type of picture. Okay, this is normal one. You can see some like gas, that is normal. So next you can see here that is okay. So this is normal abdominal X-ray. You can see here, this is here you can see liver sign, and this is we call transverse colon, and here you can see that is spinous process of L3. This is L4, and this one L5, and then after this S1. Okay, so here you can see right sacroiliac joint like this. Okay, and here this is large intestine. You can see feces is going up. Okay, and this is transverse colon. You can see here this is splenic flexor, and it's going down. So this is ascending colon, and from here that is sigmoid colon like this, and this is rectum. Okay, so this is the main things. So next you can see here that is the large intestine will be, you can see this type of picture. So this is cecum will be like wide. So this is cecum. This is, we can see ascending colon, transverse colon, and this is descending colon, and this is sigmoid colon, and this is rectum. Okay, so that is the things. Next you can see here this is large bowel obstruction. You can see here because here obstructing. Okay, so in large bowel obstruction you can see dilated transverse colon and dilated sigmoid colon and level of obstruction you can find out. Okay, so if patient have coffee bean sign, that means this is sigmoid volvulus. Okay, it will look like this. So this is also coffee bean sign. Okay, so this is we call sigmoid volvulus, and this is bent inner tube, that is we call fecal volvulus. Okay, and here you can see this is massive colon dilation. So we call this thing, massive colonic dilation because of obstruction. Okay. Next, how you can differentiate the cecal volvulus and sigmoid volvulus. So you can see here cecal volvulus means you can see that is like bent inner tube type structure you can see. And cecal volvulus, the patient will get pain in right iliac to left upper quadrant, and Haustra movements will be like present. Okay, and we can see coffee bean sign with or without an obstruction will be like with or without small bowel obstruction. The air fluid levels will be like 1 if seen. Next you can see that is sigmoid volvulus, that is you can see here. Sigmoid volvulus will be like left lower quadrant, and you can see right upper quadrant it will radiate. The Austra movements will be like negative in sigmoid volvulus, and the coffee bean sign will be like a positive, and you can see obstruction, that is colonic obstruction, and the air fluid levels will be like very few. Okay, so you can see this type of toxic megacolon. So you can see this type of bulge in stomach. So this is toxic obstruction, and obstruction it will cause very big massive obstruction because of the thing distension you can see. Okay, so next you can see here, this is the main large intestine. You can see this type of um, like dilated colon, that is we called in here you can see loss of Haustra. So you can't see this type of lines we call Haustra. So you can't see, you can see here tinea. So I'm highlighting here, this is we call tinea, like fat like structure. Okay, so you can see, so this is toxic megacolon. Okay, so the toxic megacolon will be like this, and this is toxic megacolon. It's marking already here. Okay, so this is dilated colon will look like this. Okay, next we can do CT scan. CT scan is best investigation, like gold standard investigation. Why CT means the CT scan will help to identify the cause, and it will defines the levels, and it will help to detect ischemia. Then after it will help to detect perforation. Then after it will guide surgery. Okay, in CT findings we can see dilated colon proximal to obstruction. Then after we can see transition points, mass lesions in cancers, and will sign we can see mostly because of volvulus, and pneumatosis intestinalis if patient have ischemia. Next we can see free air if you are suspecting perforation. Okay, so next you can see here CT is mandatory in all suspected um, malignant large bowel obstruction. Okay, so this is a CT scan. You can see this type of dilated large bowel and filled with gas and everything. Okay, so here you can see obstruction hernia containing this type of transverse colon, and fecal material will be there, and collapsed descending colon and distal, and dilated ascending colon in proximal. So next you can see here, that is colonoscopy. In colonoscopy, the main it will help to when we have to do colonoscopy means the colonoscopy will help for elder age and selected cases. The colonoscopy indicates like suspected colorectal cancer and diagnostic confirmation and decompression of sigmoid volvulus. In contraindications, if patient have peritonitis, perforation, or severe instability, we can't do colonoscopy, and the diagnostic therapeutic in sigmoid volvulus with colonoscopy. Okay. Next, we can see that is ultrasound. Ultrasound is like limited role but useful in bedridden patients and initial screening. So the main findings we can see in ultrasound in bedridden patient near to bed. For initial screening, we can see dilated bowel loops, fluid filled colon, and mass lesions sometimes. The gas, if patient have more amount of large bowel obstruction, if patient have gas, the gas will reduce accuracy. Okay, so next we can see severity assessment. So the severity assessment based on three different class, that is mild, moderate and severe. In mild cases we can see stable vitals, partial obstruction and no peritonitis. In moderate large bowel obstruction we can see distension and vomiting, electrolyte imbalance and no ischemia. In severe large bowel obstruction you can see peritonitis, ischemia, perforation, shock and sepsis. So next we can do management. So before management we have to, whenever patient have red flag and complications, we have to indicate ischemia or perforation and we have to do immediate surgery. If patient have continuous pain and fever, tachycardia, guarding, rigidity, hypotension and raised lactate levels, and if patient have metabolic acidosis, we have to suspect ischemia or perforation or peritonitis. So we have to do immediate surgery. So in management, if you're suspecting patient have large bowel obstruction, so first we have to see the symptoms, distension and constipation if patient have. Then we have to do clinical examination. Then after X-ray, X-ray abdomen. Then after CT scan. Then after we have to identify the cause like cancer, means we have to do surgery. If patient have volvulus, we have to do decompression surgery. Then after patient have fecal impaction, we have to go with conservative management. Then after we have to assess the complications and we have to treat based on accordingly. Okay, so these are the things. Next we can go with management. So the management main goal will be like to relieve obstruction and to prevent perforation and to treat underlying causes and to restore bowel function and to save life in emergency cases. Okay, so in large bowel obstruction the priority is not just opening the bowel, it's preventing cecal perforation and sepsis. Okay, so first, whenever you are suspecting patient have large bowel obstruction, we have to go with initial resuscitation, that is like airway, breathing, circulation. So in airway, we have to ensure the airway is patency. Then after we have to go with breathing. In this breathing, if patient need oxygen, we have to provide oxygen supplementation. Next, circulation. In circulation, we have to go with intravenous fluids. Then after we have to monitor blood pressure, pulse and urine output we have to monitor. Then after the urine output like greater than equal to 0.5 milligram per kg per hour we have to follow. Okay, so here after doing primary assessment we have to give intravenous access and nil per orifice. Then after we have to correct the electrolytes. So here nil per orifice, intravenous fluids, electrolyte correction, Foley's catheter we have to insert. Then after we have to monitor the urinary output, nasogastric tube. If patient getting vomiting or distension, we have to monitor the vitals. We have to correct dehydration. If patient because of always in bed, we have to do DVT prophylaxis. Okay, so this large bowel obstruction patients are often severely dehydrated due to third space losses. So that's why we have to give proper fluid management. So in fluid management, we can see here, we can go with normal saline, that is first line resuscitation, or we can go with Ringer's lactate for maintenance or volume replacement. Then after dextrose solutions like after stabilization. So in electrolytes, we have to correct sodium slowly. Then after we have to replace potassium only after urine output is adequate. So if patient have hypokalemia, it worsens ileus and gut motility. So in pharmacological management, what we have to do? After doing this everything, we have to do NG tube and CT abdomen. We have to identify the cause. If patient is stable, we can go with conservative management or endoscopic management. If patient is unstable and patient have perforation, we have to go with emergency surgery. So in pharmacological management, the drug don't relieve mechanical obstruction, will give only supportive. For supportive purpose only we are using pharmacological management. The main goal will be to reduce symptom, so symptom relief, infection control and pre-operative stabilization. So we can start with pharmacological management, that is antiemetics and analgesics like ondansetron, that is 5 HT3 antagonist 4 to 8 milligram. We can use intravenous 8 hourly, and the main indication will be like for vomiting. The notes, the main thing will be like the ondansetron is safe in small bowel obstruction and large bowel obstruction. Next, we have to go with metoclopramide for it will act like prokinetics. Okay, like 10 milligram we can give intravenous 8 hours now for nausea, and we have to avoid incomplete obstruction. Next, we can go with paracetamol, like it will work like analgesic, and opioids like morphine, like analgesic. Next, you can start antibiotics like if you're suspecting ischemia, perforation, sepsis, or preoperative prophylaxis, we have to start with ceftriaxone and metronidazole, piperacillin, tazobactam, and meropenem. These antibiotics are mandatory when perforated or strangulation is suspected. So we have some regimens of management. So we have to follow these regimens like first line. In first line management, we have to go with resuscitation, fluids, and NG tube and observation. Next, we can go with second line management, that is colonoscopic decompression in sigmoid volvulus. Next, alternative options we have to manage like endoscopic stunting, like malignant obstruction. Next, the final step will be like surgery. Okay. So in surgery, in surgical management, the main we can go with endoscopy. If patient have like sigmoid volvulus, patient is stable, we can go with endoscopy. Or selected malignant obstruction is there means the main procedure will be like we have to use for decompression colonoscopy, a rectal tube placement, or self-expanding metal stent. These are the things will help for temporary measure, not for definitive treatment. So we can go with surgical management. In surgical management, we have to divide. Okay, what purpose we have to do surgery? If patient have perforation, peritonitis, ischemia, and if conservative management is become failed or closed loop obstruction like sigmoid volvulus, or patient is unstable patient, or patient have malignancy causing obstruction like no delay in perforation or peritonitis. So we have some surgical procedures based on cause, that is right hemicolectomy like cecal and ascending colon cancer. Next we can see hemicolectomy and Hartmann's procedures, that is emergency left colon procedure. Next we can see subtotal colectomy, sigmoid colectomy, and stoma formation. Okay. Next you can see here there is a main procedure we called Hartmann's procedure. This is the main thing. If patient have any malignancy, or if any patient have um, ischemia, peritonitis, or cancer, we can go with Hartmann's procedure. In this Hartmann's procedure, we can see like resection of diseased sigmoid colon, okay, and closure of rectal stump. And then after we can see this is the stump. Here patient have cancer, so here they removed and they closed with the rectal stump, and here they added um, colostomy. Okay, so this is we called colostomy. Okay, so new outlet they made. Okay, so this is the main surgery will help for perforated colon cancer, severe diverticulitis, or emergency in large bowel obstruction with sepsis. If patient have volvulus, what we have to do? In volvulus, we have two different types of volvulus, sigmoid and cecal. In sigmoid volvulus, the main management will be like initial management will be like endoscopic detorsion. In definitive, we can say electrosigmoid colectomy. Next, we can say cecal volvulus like surgical treatment only, and right hemicolectomy. So this cecal volvulus does not respond well to endoscopic decompression. So this assessing bowel viability, it's like the viable bowel will be like pink, pulsatile mesenteries you can see, and peristalsis will be present, and we can see bleeding on cut. In non-viable, we can see black, green structure and no peristalsis and no arterial pulsations. So the resection must be required in non-viable. So next, post-operative care. What are the things the patient have to do? What are the things we have to do? First of all, we have to go with ICU monitoring if needed after surgery. Fluid balance we have to do. We have to control the pain with analgesics. Early mobilization we have to do to prevent DVT complications, pulmonary embolism complications, and we have to monitor the stoma if present. we have to start gradual right progression. So next we can see here complication. The complications divided into two different types. That is, whenever the doctor is asking complications, we have to divide into two different parts, early and late. In early complication, we can see perforation, sepsis, electrolyte imbalance, and shock. In late complications, we can see like adhesions, recurrent obstruction, anastomotic leak, and incisional hernia and stoma complications. For follow-up, we have to monitor the recurrence, and we have to do colonoscopy if for ruling out cancer, nutritional support, and stoma care education and electrolyte monitoring. Okay, so this is the large bowel obstruction. Mostly I covered everything. So if this video is helping you, if you didn't subscribe my channel, like, share and subscribe. You can follow me through Instagram, MedSteps MedSteps channel, and in Instagram, Dr. Anandjana. Okay, so I'm signing off, your Dr. Anandjana. So till the time, for upcoming video, we are going to discuss anal fissures and anal fistula, this type of things. Mostly we covered general surgery topics, like around 6 to 7 topics we have more. Then after, mostly we covered everything. So if you have any doubt, you can ask me in comment section. Till the time, take care. Bye bye.